let us do a discussion about the topic of amenorrhea. Now, is that one topic which a lot of my friends have been asking that we should be doing it here. Let me tell you, we've actually discussed about this in great detail individually about all the causes of amenorrhea. We've discussed about PCOS, we've discussed about Mullerian agenesis, and of course about ovarian failure and Kalman syndrome. All over the app, these discussions have been done. But yes, it makes good sense to have all of this together in one flowchart so that we can recall about it easily. All right. So let's say something about amenorrhea, the causes of primary and secondary amenorrhea. So when we say amenorrhea, that is no periods. Okay. That means a person is not having periods. Now, it can be primary amenorrhea if a woman is not having periods ever. I mean, she is a young girl who has not even started to have periods. Or it can be secondary amenorrhea. A woman who had periods is not having periods for the time being. Now, what is that time being? That is defined as no periods for 3 cycles. She's missed 3 cycles, or you can say for 3 months. You can say either way. Some books even say 6 months. So that's the definition of secondary amenorrhea. Primary amenorrhea, of course, is no periods ever. Now, we also have to know, since periods is part of the process of puberty, let us also finish off the definition of delayed puberty once more. Of course, we've done that discussion in the app of puberty, but let's have another look at it. So we say puberty time is 10 to 12 years. That's what is the normal time for puberty. But if it is no periods till 13 years, then it is delayed puberty. Or if there is secondary sexual characters, if they are present, then no periods till 15 years. She's 15 years now and she's got no periods, then we say it is delayed periods. So we can say very vehemently and very strongly that 13 is without secondary sexual characters, and if she's got some secondary sexual characters, you can wait up to 15 years to say that the patient has not had periods so far, to call it delayed periods. Now, this definition of 13 and 15 is correct, and I know some of your guidebooks and some of your other health books are telling you 14 and 16. That is ancient. It's way beyond ancient now, because the current edition of Novax is saying this, which is the edition of 2020, but the edition which came before this, the 15th edition, had said this 4 years, 5 years back. Okay, so just for your benefit, I'll show you what is written in the books. See this? This is the definition. All right, this is straight from Novax. Primary amenorrhea is defined as the absence of menses at 13 years when there is no visible development of secondary sexual characters, or age 15 years in the presence of normal secondary sexual characters. So please, this discussion finishes here. Okay, so if a person is not having periods, then how do we go about investigating and what all we should be doing? So any woman who is having no periods, whether it is primary or secondary, we would always do a urine pregnancy test. If the pregnancy test is negative, then we do the other things. See, it's a very unfortunate association, because anybody who's not having periods, any young girl who's not having periods, can theoretically be pregnant. And I say this because I've given you this example that I've myself operated on a very young girl of 13 years who was pregnant, and she was actually a case of primary amenorrhea, and she was abused by her uncle. And this happened as when I was a second year postgraduate in my college. So, these things do happen. I've seen many cases in the literature about these also. So, these are things which are unfortunate events. So, never think that a woman cannot be pregnant because she's too young or she's too old. Okay. So, do the pregnancy test. After that, we would do the examination of woman. In the examination, I would see her build, her nourishment, if she's not chronically malnourished, because that can also be a cause of amenorrhea. So in the examination, apart from the general features, I would see the developments of the breast, of the secondary sexual characters like the axillary and pubic hair, and I would look for the vagina, if it is on inspection, if it is looking normal, or if it is looking bulging, or if it is looking imperforate, isn't it? I would then do a per vaginal examination, and I would look for the uterus. if it is present or absent. And once this is done, then I will do the tests like the luteinizing hormone, follicular stimulating hormone, and thyroid stimulating hormone, prolactin, and even the karyotype if required. So these are the basic set of investigations I would do for a case of amenorrhea, whether it is primary or secondary. But yes, I would have these investigations and then I'll have a flow chart in my head. Okay, so let's see one by one what all are the problems which can cause a primary amenorrhea or a secondary amenorrhea. All right, so we'll start with primary amenorrhea. Of course, we've done the pregnancy test and the pregnancy test is negative. Now, we'll look for the secondary sexual characters, and if they are present and the woman is not having periods, it could be because that there is an anatomical defect like the uterus is absent. So, if there is absent uterus, then we know that is the Mayer-Rokitansky-Kushner-Hauser syndrome. That is the classical Mullerian agenesis. We've discussed a lot about this in the chapter of Mullerian abnormalities. She'll never have periods, isn't it? And if she has to have a sexual life, then we'll have to do a vaginoplasty just before she's planning her sexual life. Now, if the uterus is present and she's still not having periods, then it still could be an anatomical defect. Like if there is a uterus like this, the cervix is formed, vagina is formed, but the outflow channel, the hymen has not cannulated, imperforate hymen, or there could be a transverse vaginal septum like this, or rarely the cervix itself could be absent, like in a cervical atresia. So that also can cause a problem of periods. So imperforate hymen, transverse vaginal septum, and cervical atresia. Mind you, all these three can be corrected surgically and we can make such women have periods regularly. Okay. Now, if the uterus is present and still the person is not having periods, let's take it from here, then we've already done the LH and the FSH like I told you in the previous slide, and the thyroid stimulating hormone, prolactin levels, all of these have been done. So if these all have been done and still the person is not having periods, then we must see if there is a problem of hypothyroidism or a hyperprolactinemia. These can actually present with primary amenorrhea. Or is there a hypergonadotropic? That means the gonadotropins are made in a good amount, the hypothalamic and the pituitary axis, till there things are okay. Hypothalamus is stimulating the pituitary to make the FSH and LH, gonadotropins. So hypergonadotropic, that is increase in LH, increase in FSH and still not having periods, then that is a pure gonadal dysgenesis. And if there is a hypogonadotropic hypogonadism, that means LH and FSH are low. Now, LH and FSH low in a young girl can be because of nutrition problem. She's a young girl who is having secondary sexual characters but not having periods because of a severe chronic malnourishment. Or she's having a chronic illness, or she's an anorectic. So yes, correction of this can help her have periods. And these are the problems when a person is having sexual characters properly but not having periods. Now let's move on and see why somebody will not have periods, because there is presence of secondary sexual characters of the asynchronous type. Now asynchronous, that means the sex of a person is one, but the secondary sexual characters are of the other sex. Classically, we would see that in a case of androgen insensitivity syndrome, also known as the testicular feminization syndrome. You know that when you look at the person, it looks like a girl and she's got all attributes of femininity, but when you examine, you see that there is a blind vagina and there is no uterus. Seen on ultrasound or a per rectal examination, you don't find a uterus. So yes, androgen insensitivity syndrome or a testicular feminization syndrome, like we call it. Now, the secondary sexual characters, if they are present, we've discussed. If they are asynchronous, we've discussed. What if the secondary sexual characters are absent? Now, if the secondary sexual characters are absent, now we have a problem. We have already done, like I said, the LH and the FSH. Let's go by this again. And if they are high, that is hypergonadotropic hypogonadism, again, that is high FSH and LH. That means the hypothalamus and the pituitary are doing the work, but the ovary is not responding. Now, in the presence of secondary sexual characters I have discussed, in the absence of secondary sexual characters, high LH and FSH means a primary ovarian failure. Can also be seen in gonadal dysgenesis, like the Turner syndrome, and it can be seen in conditions where there is a FSH and LH receptor defect. It can also be seen in galactosemia. Galactosemia, the galactose, high concentration of galactose and its metabolites are detrimental to the ovarian stroma and the ovarian follicles, and that can also cause the patient to have a ovarian non-responsiveness to the high amount of LH and FSH which is present. Now, in the condition of absent secondary sexual characters with high LH and FSH, we discussed. But if the LH and FSH is low, that is hypogonadotropic hypogonadism, low LH and FSH. Now, that could be because the hypothalamus and the pituitary axis is taking time to mature in a young girl. So, that could be a physiological delay also. Or it could be because of a Kallmann syndrome, which is a classical case of hypogonadotropic hypogonadism, low LH and FSH. And it could also be because of CNS tumors. The hypothalamic or pituitary tumors can also present with primary amenorrhea because of low LH and FSH. All right. So, let's go and see what could be the causes of a secondary amenorrhea. So, in a case of secondary amenorrhea, of course, we have done the pregnancy test here also, and the pregnancy test is negative. I would want to check hormonal problems because she was having periods so far and now she's not having 3 cycles or 3 months she's not having periods. Then I would do the TSH, and if she's got a hypothyroidism or a hyperprolactinemia, I would correct that and she would get a periods. Now, in spite of having a normal thyroid and a normal prolactin, she is not having periods, then I must see that why is she not having periods. Let me give her a progesterone challenge. That is, a woman, let's say she is around 25 years, she isn't having periods always, regularly, now she is not having periods and she is not pregnant. Hypothyroidism is ruled out, hyperprolactinemia is ruled out. All these things are normal. So, maybe she's having a problem with her hormones. Let's go step by step. So, I give her a progesterone challenge. I assume that maybe the estrogens are formed and maybe she's not ovulating properly, so she's not having progesterones, and because of not having progesterone, there's no secretion, and when the progesterones fall, women have periods, isn't it? So, let me give her a challenge. I give her a challenge, and progesterone challenge test is classically that I give her medroxyprogesterone acetate, any progesterone tablet, okay. So, I give her progesterone for 5-6 days, and after giving the progesterones, I abruptly stop them. So, if there was estrogen primed endometrium, MCQ for you, if there was a estrogen primed endometrium and I give progesterons to make it secretory and abruptly stop it, she will get periods. So if she gets periods, if the progesterone challenge test, if we give and she gets periods happen, then we know that it's a case of polycystic ovarian disease. Okay, classical example for you people. Of course, in the chapter of amenorrhea, I am not giving an endless list of possibilities in both primary and secondary amenorrhea, because the list is actually very big, and those vague syndromes generally don't come in your exams, and they are so rare that even you don't see them in your journal practice. I mean, if you see them, then going by these algorithms, you'll be able to derive those rare syndromes also. So let's go by the common things which are generally asked in your exams. So yes, if the periods come after progesterone challenge test, we know it's a case of a high estrogen situation without progesterone. That is classically seen in the cases of polycystic ovarian disease. Now, when you give the progesterone challenge test and that comes negative, that means no periods. So now you have a problem that maybe the estrogen itself is not forming properly. So then we give her a estrogen and progesterone challenge next. So next is to give a estrogen plus progesterone challenge. So I give the exogenous estrogen to make the proliferation, and I give the exogenous progesterone to give the secretion. Let's say I give estrogen for around 16 to 21 days. Normally give for 21 days, and then for the last 5-6 days I add progesterones. So estrogen and progesterone should make an endometrium grow and become secretory and menstruate. In spite of that, it does not happen. Suppose after the estrogen progesterone challenge there is no period still, then that means this uterus is having a destruction of the lining. This endometrial lining is so damaged that estrogen and progesterone is not making it grow. That happens when there are these, yes, adhesions, synechiae, which is classical of the Eschermann syndrome. Okay, so estrogen progesterone challenge, no periods, then it is Eschermann syndrome. Now, estrogen progesterone challenge you get, and she gets periods. If the periods come after the estrogen progesterone challenge. Now, what could be the possibilities? That only after giving exogenous estrogens that the uterus responded. Could be because of a condition where there is high LH and high FSH and the ovary is not responding at all. So those are the conditions where there is premature ovarian failure. Yes, LH and FSH high and the patient is not getting periods. That's classically in menopause, isn't it? But now she's a young girl of, let's say, 25-30 and she's not having periods and her LH and FSH is very high. That means the ovary has lost the capacity to respond to this hypergonadotropic condition with hypogonadism, we call it. So hypergonadotropic, ovary not responding, hypogonadism, premature ovarian failure. That can be one of the causes of this. Yes, it can also be because of a patient having ovarian injury because of, let's say, radiotherapy, or let's say because of chemotherapy. It can be a surgical menopause, a oophorectomy has been done. Sometimes patients will come to you and say that they're not having periods, and then you take the history and find out that she probably had a surgery in which the ovary was removed. Maybe she had only one ovary and that ovary was removed, or maybe she had both the ovaries removed because she had a ovarian tumor on one side and the doctor thought it's best that we remove the other ovary also, and that was not discussed with the patient. That has happened so many times in our practice. We've seen such cases. So yes, there's oophorectomy, or there's an ovarian injury, or there's a premature ovarian failure. When do we call it premature ovarian failure? A patient not having ovarian function before 40 years. After 40 years, it's assumed around 47 to 48, most women will have menopause. So around that time, 45, 48, 50, 55, if somebody is having menopause, it's okay. But if she's having ovarian failure before 40 years, it's too early. to say menopause. So then we call it premature ovarian failure. We have discussed that also in detail. So yes, these will tell us that it's a hypergonadotropic hypogonadism. Now, it could be hypogonadotropic. That means reduced FSH and reduced LH and patient not having periods. That comes in conditions where the central nervous system has taken a beating. There could be CNS tumors, there could be chronic illnesses, or it could be the classical Sheehan syndrome, the postpartum pituitary necrosis, where the pituitary is not having the capacity to respond to the hypothalamic stimulation and there's no LH and FSH. That's why the person is not having periods. All right. So that's the list of conditions which you have to rule out when there's a secondary amenorrhea. Now, having said both these lists of primary and secondary, let me remind you, we have already discussed these conditions in great detail in the app. But yes, most of you want to have a flow chart to think how these things are thought about when there's a patient of amenorrhea. And let me tell you, there is no strict compartment that, okay, primary and secondary. We always don't think in such strict compartments because there is a lot of overlap in these things. Okay, let me show you this. Primary amenorrhea, secondary amenorrhea, the conditions like I discussed, but quite a few of them come in the common etiology. Like I discussed with you, disorders of sexual development, gonadal dysgenesis, Mullerian agenesis, and androgen insensitivity, physiological delay, transvaginal septum, etc. Then we discussed pituitary lesions and Sheehan syndrome just now. Of course, one more lesion is the cervical stenosis. Yes, if the cervix has stenosis secondarily because of some infections or repeated DNCs, then cervical stenosis can also cause a secondary amenorrhea. So, primary and secondary, they are the causes which are, attributable primary to these headings. But some of them could be common etiologies. That's why I was saying it's very difficult to put them into one compartment. Like pregnancy was there in both, hypothalamic pituitary tumors was in both, chronic illnesses was in both, similarly hyperprolactinemia and the other diseases like PCOS and thyroid disease. Yes, PCOS can come with primary amenorrhea, but what is your take-home message? You know that PCOS is classically secondary amenorrhea, but yes, PCOS can present so early sometimes that the girl never had periods to start with. So yes, classically PCOS is secondary amenorrhea, but can have primary amenorrhea also. So I'll repeat that you cannot put them into such compartments all the time, but yes, there was a requirement that we should know a good flow chart to understand how primary and secondary amenorrhea manage. So that's what we've done in this. All right. I hope some clarity has come to you in getting all this information together in one place. All right. So before we see the revision of prolapse, let's quickly see the supports of the uterus. So if you see the uterus, it is right in the middle of the pelvis, and this is the vagina. If you see a coronal section from the pelvis, the round ligament comes from the fundus of the uterus. Now it goes through the internal inguinal ring and comes and settles into the labia majora in front, and some fibers go into the mons pubis also. So the round ligament, like we know, it's from the fundus of the uterus and goes and holds the labia majora in front like this through the inguinal canal. So that's why the uterus is anteverted, because of the round ligament. That's a very common question also asked. From the sides of the uterus, we see the McEnroe ligaments, and this is front view of the uterus. Now if you turn the patient like this and take a sagittal section and see the uterus from the side, so from the side you will see another support, another ligamentous support, which comes from the back of the uterus to the sacrum, and that support is the uterosacral. So this is the uterosacral ligament, and this ligament from the side is the McEnroe ligament or the transverse cervical. All right, here. The transverse cervical. Now, mind you, this transverse cervical is the same known as the McEnroe's. Also known as the cardinal ligament. Now, these are the ligamentous supports of the uterus: the McEnroe's, the round ligament, and the uterosacral ligament. Now, out of this, which is the best support of the uterus? No doubt, the best ligamentous support of the uterus is the transverse cervical or the McEnroe ligament, also known as the cardinal ligament. So we are talking about the best ligamentous support so far. Now do not get confused when they ask you about the best support of the uterus. It is none of these three. It is definitely not the broad ligament also. Please, the broad ligament is hanging from under the round ligament like this. This is the broad ligament area. And if you imagine, this broad ligament itself is hanging. It is itself hanging from the round ligament. So the broad ligament is no support to the uterus. It is itself taking support. This is the round ligaments. The broad ligament itself is taking support from the fallopian tube. So broad ligament is not a support of the uterus. Some of your books are saying that actually. It's wrong. Okay. So this three ligaments, the best support is the transversocervical ligament. Now, which is the best support of the uterus overall? To understand that, let us look at the pelvis from below. This is a pelvis which is upturned like this. Suppose a woman is standing like this and her pelvis you upturn and show you the outlet. So this is the outlet of the pelvis. You can see this is the symphysis pubis and this is the sacrum here. And this pelvis, the outlet of the pelvis, view from below of the pelvis, the uterus is somewhere here. The rectum is somewhere here. Alright? Can you imagine this empty space? The uterus and the rectum is going to come out every time, isn't it? Every time the one cuffs, the uterus is going to come out. So that's why we say there has to be some support. So just now I told you, there are some ligaments, some ligaments going from the sides of the uterus, and there's some ligaments which are coming from the front of the uterus, the round ligament, and something from the back. But those ligaments are just ropes. This pelvis, the base of the pelvis is so wide and huge that anything which is suspended by ropes also will still hang out of the empty pelvis. So this outlet of the pelvis needs to get filled up from both the sides. Yes, this pelvis needs to get filled up from both the sides with muscles like this. It will come, muscles will come and fill up the pelvis. So yes, muscles from the pubis to the coccyx. See, the pubis to coccyx, pubis coccyx, pubococcygeus. Muscles from the ilium to the coccyx, iliococcygeus, from both the sides. And then ischium to the coccyx, ischio-coccygeus. So muscles from all the three bones will come and entwine the uterus and the rectum. And this will make a mesh of muscles which will avoid the uterus and the rectum to come out. So yes, let's see that in a picture here. This is that picture which I was making. If you see, this is the cut section of the uterus and this is the cut section of the rectum. This is the anterior part of the pelvis, this is the posterior part, and muscle. See this? See, this muscle is coming from this is the pubococcygeus. Then this part of the muscle is the iliococcygeus. Then the ischio-coccygeus. They will all come from both the sides and entwine the uterus and the rectum. So this will make these muscles, which are coming from both the sides. I'm trying to show you like this. This will make, actually, if you turn the woman's and make her stand, this will make a floor of the pelvis. The floor of the pelvis made by these three muscles: pubococcygeus, iliococcygeus, and ischio-coccygeus. So these three are the best supports of the uterus. Overall best support of the uterus are these three muscles together. So these are known as the levator ani. Okay, the pelvic floor, or the pelvic diaphragm also we call it. So pelvic floor, pelvic diaphragm, or the levator ani, it is no doubt the best support of the uterus. So this is like a trampoline, If you imagine the uterus and the rectum, they are like the two gymnasts sitting over this trampoline like this, uterus in the front and rectum at the back. So you see the openings of the uterus and the rectum, the two openings of this levator ani like this. But the muscles are coming from the sides and entwining these two openings. So that's why every time the woman cuffs, it's like like this. The muscles will go down, but they will bounce back. So this is a dynamic support of the uterus, the levator ani. This will support the uterus and the rectum and avoid them to come out best. Yes, out of ligaments, the best is the McIndots, but overall the best support is the levator ani. Also the axis of the uterus, the axis of anteversion and anteflexion, that also prevents the uterus from coming out. Prolapse of the uterus, which is classified by the Shaw's system or by the Jeffcoat system or by the pelvic organ prolapse quantification system. So there are many classifications, many ways of staging the prolapse, 1, 2, 3, and 4 by Shaw's. Jeffcoat is 1, 2, and 3, and the degrees from how much from the usual place the cervix has come down minimally to the introitus or outside or totally outside. Like that, there are so many classifications of prolapse. They're not asking you about the classification of prolapse, but yes, one question which I saw in some exam was, which is the best way of diagnosing categorizing prolapse, and that best way of categorizing prolapse is the pelvic organ prolapse quantification system, because this is what is internationally accepted, and inter-observer variation is very less in this. That's why it is the most well accepted way. So yes, this is why you make a grid based on the marks on the anterior wall and the posterior wall and at the apex of the vault of the vagina. So based on that, we are making a full grid. So that's a little complicated. Some other forum we can discuss about that. For the time being, the classification of prolapse, the main systems I've told you. Let's move on and see how does a patient have prolapse. So yes, we all know the prolapse is basically because of the abnormal conduct of labor. Abnormal conduct of labor, or it can be because of connective tissue disorders like Ehlers-Danlos and Marfan syndromes, and so many other types are there. Then spina bifida and increase abdominal pressure. Increase abdominal pressure because of mass in the abdomen or ascites. So the abdominal pressure is too much, and that can cause the pelvic organs to move out of the pelvis. So yes, the main reason for prolapse is the abnormal conduct of labor, and all of you know abnormal conduct of labor means early bearing down, prolonged second stage, faulty instrumentations, multiple perineal injuries, and early resumption of work, and multiparity. There's so many features of abnormal conduct of labor, so many things which a person can do wrong in labor, which can lead to prolapse later on. So yes, how does a prolapse present to you? So we always see, if I show you the woman's pelvis from the side in a sagittal section, so yes, there's a sacrum here. So if you see that if you slice a woman like this and show the pelvis from the side, then the peritoneum from the top of the abdomen comes like this, goes over the bladder, behind the bladder over the uterus, behind the uterus over the rectum. So you know this is the pouch of Douglas, and this is the uterovesical fold of peritoneum. So when there is prolapse, whether it is type 1, 2, 3, 4 of Shaw's, when the uterus is moving out, the uterus, when it moves out with the bladder and the rectum, because the bladder and the rectum is stuck to the uterus with the peritoneum. See, the UV fold is making the bladder stick to the uterus. The pouch of Douglas, this fold, the rectouterine fold of peritoneum, this is making the bowel stuck to the uterus. So when the uterus moves out and prolapse like this, what happens? The organs which are stuck to the uterus will also move out in prolapse. So yes, this bladder will move out in prolapse, and this rectum will move out in prolapse. If you see closely, this vagina, can you see this? These two lines, this is the vagina. So this vagina will also move out with the uterus. So yes, when the uterus comes out, it doesn't come out alone. Yes, the uterus has 2-3 friends with him. They're stuck to him. So when the uterus hangs out, he hangs out with his friends, isn't it? So this vagina comes out like this, the posterior vagina comes out like this, and then the bladder comes out, and the rectum comes out. So see, these are the parts of the prolapse. This is the cystocele, this is the rectocele, and this is the uterus coming out. Because of the bladder coming out, what are the problems? We know that biggest problem of a bladder, which is supposed to be like this, and the bladder goes out like this. The biggest problem is that the patient cannot urinate properly. What do all of us do? We increase abdominal pressure to urinate, isn't it? So when the abdominal pressure increases like that, then the bladder compresses and the urine goes out. Now look at this woman. When she strains to urinate, the bladder goes out like this. How will she urinate? She cannot urinate. So it's very, very demeaning and very, very embarrassing for her that she has to hold a uterus. And with this, she has to put the uterus back into her body like this. So with the hand inside the vagina and pushing the uterus, she has to urinate. And the urine part of it is falling over her hand. It's very, very depressing for her. And most of it stays back in the bladder and can cause retention, infection, stone formation. All right. So that's the problem because of bladder. Similarly, rectal problems like fecal formations can happen. And what we can do to give her relief, we can push the uterus back inside and hold it inside. Yes, we can push the uterus back inside and hold it inside with the pessary like this. That pessary will hold the uterus inside so that she can urinate and also defecate properly. So why do we use the pessary? Why don't we just treat the patient off? Because when the uterus is hanging out, it could be hanging out for many days or many years sometimes. And that's why the uterus, the blood supply of the uterus is not very good. So if I do a surgery of cutting off the uterus, see if I do a surgery of cutting off the uterus, what is this? This is the vaginal hold on the uterus. If this uterus and vagina is hanging out for a very long time, the blood supply is very badly compromised. So these cut-ends I'm going to use, the uterus is out, but the cut-ends I'm going to use for stitching. Those cut-ends won't be having a very good blood supply, and that's why the healing of the wound won't be very good. So very important, when you see a prolapse and the prolapse is congested, you all remember in your gynae days that whenever a prolapse is hanging out for a long time, it will be edematous, it will be swollen. And some of these women will also have some ulcers on the cervix. Why those ulcers form? Because they see this uterus, vagina, and if this uterus is hanging out of the vagina like this, this vagina will be compressing the blood supply of the uterus. So what does this compression of the vagina do? It stops the arterial? No. Arterial flow is 120/80. Pressure is too much. It will definitely reach the uterus, but the venous return will be compromised. When there is venous return compromised, there will be venous congestion of the uterus. Venous congestion is what blood? Deoxygenated blood. So that deoxygenated blood, the uterus is all deoxygenated and it is hanging between her legs. When she's walking, it rubs between her thighs. She sits on a chair, it rubs on the chair. So it causes small ulcers, small erosions, and those will not heal because the blood supply, the blood here in the uterus is all deoxygenated. So that's why these ulcers won't heal and they'll become chronic, non-healing decubitus ulcers or dependent ulcers. So yes, that's why we say push the uterus back inside with the ring pessary. When you put a ring pessary like this, the decubitus ulcer will become healed because the venous return will be good, arterial supply will be better, and the healing will be there. And also the micturition and the defecation problems will be taken care of. So pessary treatment is a good treatment, but it's temporary treatment. It is not a permanent treatment. What is a permanent treatment of prolapse? You know that prolapse happens only to mostly to older women around 55 to 65 years of age. So what would you want to do for a uterus which is hanging out of the vagina like this? What would you want to do? Obviously, an old lady, you'd want to take it out. One of the simplest surgeries is to take out the uterus from the vagina. Yes, of course, for a practicing gynecologist. So this uterus has come out in the surgery. This is the vaginal hysterectomy. Now, vaginal hysterectomy has been done. So I'll write here vaginal hysterectomy. Now, when the uterus is out, that part we did not want, but the bladder and the rectum we want. So we'll push the bladder back inside. We'll push this vagina also back inside. So let me draw this again. Now I'll push the bladder back inside. The vagina was hanging out. I'll push the vagina also back inside. Similarly, posteriorly also I do something similar. I push the rectum back inside and I push this vagina also back inside. So now you see this. This was the normal uterus had gone out I remove the uterus. Now I push the bladder back inside and the vagina back, and I push the rectum back. But there is a hole in the vagina here. I suture this hole. Now this is known as the vault of the vagina. This is known as the vault, the highest part of the vagina, or the vault. And yes, this anterior vagina, which was hanging out like this, has been pushed back inside. So this is a loose vagina. The bladder will hit on it and come out again in a few days. The posterior vagina is also loose. The rectum will hit on it and come out again. So what is done? What we do? We make sure this vagina doesn't go out. So we tighten the anterior vagina. We tighten the posterior vagina. So yes, that is what is the repair of the bladder. The bladder should not go out. The cystocele should not go out. To make sure that the bladder or the cystocele not to go out, we tighten the anterior vaginal wall. And for making sure the rectum doesn't go out, we tighten the posterior vaginal wall. So the vaginal opening, is so big in prolapse, we close the anterior wall and close the posterior wall like this. So the vaginal opening stays the normal size. So yes, anterior vaginal repair, vaginography. Vagina is also known as colpos. So yes, for cystocele we do the anterior colporrhaphy, and for the rectocele we do the posterior colporrhaphy. But remember, posteriorly there is also the perineal body here between the vaginal opening. Look here, I'll show you here, between the vaginal opening and the anal opening. What is this area? This is the perineum. So anterior colporrhaphy, posterior colporrhaphy, but posterior also perineorrhaphy. So posterior colpoperineorrhaphy, posterior colpoperineorrhaphy. So what am I doing? What am I doing when I'm doing the anterior wall repair and the posterior wall repair? I am repairing the anterior vagina and the posterior vagina. This anterior vagina and the posterior vagina is essentially a defect. Yes, it's essentially a defect in the pelvic floor. So what is the conclusion regarding the chapter on prolapse? Please remember, when you're doing a Ward-Mayer surgery, or otherwise also known as vaginal hysterectomy with pelvic floor repair, please be very, very careful that if you're not doing the repair of the enterocele, she can have a prolapse of the vault in around 3 to 4 months. And if you do not do the proper colporrhaphy, vagina anteriorly and posteriorly, if you're not doing that repair properly, what else can happen? So if you see the uterus, the anterior vagina, posterior vagina, and the urethra on the top, abdominal wall. So suppose I've done the hysterectomy here, and after doing the hysterectomy, you close the vault. I'll show you. You close the vault. You've done the anterior colporrhaphy. You've done the posterior colpoperineorrhaphy properly. But if you've not done a good surgery and you've not repaired the anterior wall properly, this anterior wall, look at my hand, this anterior wall will slacken. This anterior wall can slacken like this. It may come down like that. So if this anterior wall comes down like this, then the urethra, which is above this, the urethra will also come down like this. All right. See, the anterior wall has come down. I'll show you in a different color if there's a confusion. See, the anterior wall has come down and the urethra, which was sitting above it. See, the urethra is supposed to be like this. But if the urethra becomes straight like this, see, straightening of the uretrovesical angle, the angle which can cause a stress incontinence. Yes. So you've done a surgery, you've done the anterior repair, but you've not done it properly. So a patient after hysterectomy can also have a stress incontinence. After a surgery, you've done the surgery, probably before the surgery she did not have anything like a stress incontinence, but since you did not do a proper repair anteriorly, she can have a stress incontinence, and this can come in within 2 to 3 weeks. You don't have to wait as much as 3 to 4 months in a case of a wall prolapse. A stress incontinence, if the anterior vaginal wall repair is not done properly, can present to you in 2 to 3 weeks. All right, so let's see a couple of surgeries for the stress urinary incontinence. I'll try to show you in a diagram this way first. So stress incontinence surgeries, I'm not trying to say that stress incontinence always happens as a complication of prolapse. No, as a prolapse surgery complication, it is one of the reasons which causes stress incontinence. Stress incontinence might be an isolated event because of pelvic muscle weakness, and she may not have a prolapse, but just a stress incontinence. So let's see surgery. I'm just talking only about stress incontinence. I have moved away from the prolapse topic for the time being. So let's see. This is the pubic symphysis, and suppose this urethra is down. In this diagram I made it very straight, but suppose this urethra is a little down like this. So you want this urethra to be pulled up. That is what is this straightening of the uretrovesical angle. This straightening of the angle I told you is the cause of the stress. So you want to pull up this angle like this. So to pull it up, you can take a rope on top from the urethra and pull it up like this, isn't it? You can pull a rope and do this. Or you also know that this urethra is sitting over the vagina. So something can be taken into the vagina and the vagina can be lifted up. So yes, either you can take a rope which can go from above the symphysis below the bladder neck and go up like this, and we can tie it up like that. So when you pull up this rope, the bladder neck will go up. Or you can take another rope which goes below the vagina and you can take it up like this. So the red rope is pulling just the urethra. The purple one is pulling the whole vagina up. So needless to say, if this is the antivagina and you pull up the antivagina, if you pull up the antivagina, then the urethra will also go up. So yes, the first surgery is the one in red, is the needle suspension. Is the needle suspension procedure. The one in purple is the colpo suspension. It goes by various names. The colpo suspension surgery goes by the Birch colpo suspension or the Marshall-Marchetti-Krantz colpo suspension. And you've been asked questions on these. Don't think these are out of course kind of things. Okay, please. We are having a revision. I'm trying to tell you as many surgeries as possible here. Or you can also do the Kelly stitch. What is a Kelly stitch? Kelly stitch is bladder neck plication. What do you mean by plication? You know, I was trying to tell you this bladder neck is straight. So if you want to, this bladder neck which is straight, if you want to pull it up like this, then you can take a rope on the top, or you can push the vagina up like this, or the paraurethral tissues. See, I'm showing you like this now. The paraurethral tissues at the bladder neck, you can pinch them below the bladder neck. See, again I'll show you. Paraurethral tissues you can hold and pinch. Pull them down below the bladder neck. So the neck will get lifted up. Plication of the bladder neck. That is a Kelly stitch. You must have, in your internship, you must have seen the surgery happening many times along with the basic vaginal hysterectomy. Kelly stitches, possibly almost 70-80% of, at least 50-60% of the vaginal hysterectomies, we put a Kelly stitch so that the bladder neck gets elevated a little bit. And the last in this is the regularly asked one is the tension-free vaginal tape. Now, what is this? I'll try to show you from the front of the woman now. So this is the bladder, this is the urethral opening, this is the vaginal opening, and this is the clitoris here. So from the obturator foramina, what do you have to do? You have to take a tape. You have to take a tape from the vagina into the obturator foramina, and from the inguinal canal you have to come out like this. Both ways you have to do this surgery. So this tape, which is going from the vagina to the side of the vagina and through the obturator foramina into the inguinal canal, and comes up like this and comes up like this. So this tape, if you pull it up like this, it lifts the vagina. That vaginal lifting will also lift up the urethra. Same principle of pulling up the urethra. So let's see what I mean by this tension-free vaginal tape. I'll show you in some pictures. All right. So if you see this surgery, look, the same tape I'm trying to show you from a model of a pelvis. From this the bladder here, this the bladder here, and from under the bladder, this the bladder and this the urethra. From under the urethra, you see this blue tape is going. So this is obviously in the vagina. We've gone on the side of the vagina through the obturator foramina and we've come up. And similarly, from the obturator foramina, we've come up. So if you lift this, the urethral neck will get lifted. I'll show you in yet another diagram. See, this I'm showing you in a sagittal section from the left. So if you see, this is the bladder and this is the uterus here. And if you see the urethra here, this is the urethra. So there's a tape which has gone from below the urethra. See this white color tape, it has gone like this, and from the other side also. See, this is the urethra. I'll make it dotted. So below the urethra, this is gone. Okay, I'll take this out. Below the urethra, this white tape is gone. So when you pull this white tape, the bladder neck will get elevated. So these are the this is the tension-free vaginal tape, and I'll also show you the colposuspension procedure, one which I had just now drawn. The colposuspension, let's say the Birch colposuspension, what is that? You lift the antevaginal wall. So I'm showing you pelvis from the top. If you slice a woman, like this, you slice a woman and show the pelvis from the top. So this is the anterior part of the pelvis, this is the posterior part, and this is the uterus, and this is the bladder. So if you see the bladder, can you see this elevated one tube-like structure going out from the bladder? That's the urethra. And what is below rather, this urethra? This is the vagina here. This is the vagina on the sides. So that urethra is sitting over the vagina, we can see. So there are some ropes we take. See, we take some ropes from the vagina and we pull up the vagina. So when we pull up the vagina, the bladder neck will get pulled up. So we tie to the Cooper's ligament here. See those ropes? We tie up those ligaments like this. From the vagina, we've taken the ropes and we tie these ropes to the Cooper's ligament so that the vagina gets lifted up and the urethra gets lifted up. So that is the Birch colposuspension. So these are the procedures by which we can treat the stress urinary incontinence. The question asked of you people in one of those exams was, which one of these 4 procedures is going to have the best long-lasting results? Yes, that's a question. Out of stress incontinence surgeries, needle suspension, colposuspension, Kelly stitch, and transvaginal tape, which one of these surgeries will have the best long-lasting results? So the answer to that question is the mid-urethral slings. Just like we described now, the mid-urethral slings can be the tension-free vaginal tape or the transobturator tape. So these 2 types of tapes which are used for mid-urethral suspension, the transobturator tape was actually made so that it has lesser complication as compared to the tension-free vaginal tape or the transvaginal tape. So it was supposed to have lesser complications, but the complications are not much lesser in TOT as compared to TVT. So either of these can be used as the mid-urethral slings for the best results now, because yes, I have myself taught till so many years that the best results have been achieved by ventral suspension. But now we have overwhelming evidence. Even in Novak's Gynecology, the 2020 edition, it says categorically that for the last 17-18 years, so much of data has been accumulated for the transurethral slings. And this data shows that the survivors of this surgery are so well that the method of choice, the gold standard from ventral suspension, have now gone towards the tension-free vaginal tape and the transobturator tapes, or simply said the mid-urethral slings. Let's see CA vulva. Now CA vulva, in CA vulva, very important is the stage 3C. In stage 3C only the lymph node involvement is discussed. Whenever you read CA vulva, remember, we must think of the lymphatics as the major discussing point. The lymphatics from one side of the vulva can drain into the other side. From the cancer, suppose, is on the right labia, the left lymphatics can be involved. There's crossing of the lymphatics in vulva. So yes, stage 1 is limited to the vulva. And stage 1, remember the salient lines which I'm going to, salient features, okay? It's a very confusing staging, it's a little detailed staging. Let's remember just the very, very basic things. That stage 3 is when the lymph node involvement will start coming. Stage 1 and stage 2 has no lymph node involvement. That's one point. Now stage 1A, it is limited to the vulva, we know. Less than 2 centimeters size and less than 1 millimeter depth of invasion. And stage 1B, more than 2 centimeters size and more than 1 millimeter depth of invasion. Okay, so less than 2, less than 1, more than 2, more than 1. That is stage 1 of CA vulva. Now stage 2. Stage 2 is involvement of the adjacent organs. Stage 4 is involvement of the adjacent organs. Stage 2 and stage 4 are similar that way. In stage 2, there is any size of tumor with extension to the adjacent perineal structures. So if you imagine the vulva, what are the organs around the vulva? Above the vulva, you have the urethra. Behind the vulva, there is the vagina. Below the vulva is the anus. So adjacent organs are involved in, say, vulva, then it is stage 2. So whatever the size of the lesion, adjacent organs are involved. So what are the adjacent organs? The lower urethra, the lower vagina, and the anus. Now same logic, remember, in stage 4, adjacent organs are involved, but the upper part of the adjacent organs. So that's how I remember this staging. So the adjacent organs are involved in CA vulva, the lower urethra, the lower vagina, and the anus. What are the adjacent organs? Upper part, upper urethra. Urethra is a very small organ in a woman, so upper urethra is basically the bladder. So upper urethra and the bladder, upper vagina, and then upper anus. Now there's nothing called upper anus, so it's the rectum, isn't it? So that is stage 4. You can see that upper urethra, upper vagina, and it will also involve the bladder mucosa and the rectal mucosa. So that is what is stage 4. We'll try to remember it that way. That stage 1, there is less than 2 and less than 1. 1B is more than 2, more than 1. Stage 2, adjacent organs are involved. Stage 4 also, adjacent organs are involved. But in stage 2, the lower part of the adjacent organs, and stage 4, upper part of the adjacent organs. These are the basics. And what's the other basic? That the inguinal lymph nodes are involved only in stage 3. So stage 2, tumor of any side with extension to the adjacent perineal structures, lower 1/3 urethra, 1/3 vagina, and anus with no nodes. Stage 3, any side, any extension, but positive inguinofemoral lymph nodes. Positive inguinofemoral lymph nodes. All right. So let's see. Let's take out all of this and try to see it without any clutter. So stage 3, the lymph nodes are involved. 3A, 1 lymph node, more than 5. 1 to 2 lymph nodes, less than 5. Now you would say, if the growth is in the lymph node and the lymph node is bigger, then it should be higher staging. In CA vulva, the logic is more the number of lymph node involvement, worse is the prognosis. So if you're getting confused, let's take out the confusion now itself. It's not the size. If there is one inguinal lymph node which is more than 5 millimeter in size, that is a very early stage, stage 3A1. But if it is 1 to 2 lymph nodes less than 5 millimeter, it goes into stage 2A2. All right. Now let's see what is stage 3B. 3B is 2 or more lymph nodes of more than 5. See, as the numbers increase, the staging goes higher. Or 3 or more lymph nodes, but less than 5. So as the numbers increase, less than 5, but the number is 3 or more, then that is becoming 3B2. Okay. So yes, I know that stage 3C, only thing they will ask you in stage 3C, I know very well in CA vulva, they'll ask you inguinofemoral lymph node involvement. What is the stage? You have to say stage 3. That's the end of it. They will not ask you these minute details. But yes, if you're reading, you must read completely. So I'm telling you that inguinal lymph node and inguinofemoral lymph node involvement, the more is the number, higher is the staging. So don't get confused by the size. More than 5 millimeter is lesser stage, and less than 5 millimeter is a higher stage, because when it is less than 5 millimeter, the number is more. Now let's try and decipher stage 4 once more. Stage 4, I told you, is the stage where the cancer has spread from the vulva to the adjacent organs, but the upper part of the adjacent organs. So read stage 4A. Stage 4A, tumors invades any of the following. Tumor invades any of the following: upper urethra, upper vagina, bladder, rectum. This is what I already told you as the introduction to the cancer of vulva staging, that when the upper part of the adjacent organs are involved. Then, very important, fixed to pelvic bone. The growth is fixed to the pelvic bone. Okay, that is 4A1. Now 4A2 is fixed or ulcerated lymph nodes. Do not get confused. If the growth on the vulva is involving the adjacent organs and the upper part of the adjacent organs, it is stage 4. Now that growth is fixed to the pelvic wall, that is stage 4, but that is stage 4A1. It's the growth stuck to the pelvic walls or the pelvic bone. But yes, if it is fixed or ulcerated lymph nodes which are coalesced together, fixed or ulcerated lymph nodes which are coalesced together, that is stage 4A2. Okay, so fixed growth ulcer. See, if this vulva is having, see this, there's an ulcer here. This is the cava vulva. This growth is fixed to the pelvic bone. Now that is stage 4A1. The growth is fixed to the pelvic bone. But if there are many lymph nodes which are fixed to each other and they are ulcerated, now that becomes 4A2, fixed or ulcerated inguinofemoral lymph nodes. Okay, and stage 4 is the worst stage. Any distant metastasis or involvement of the pelvic lymph nodes. See, this word has come only now. Pelvic group of lymph nodes is not a primary group of lymph node involvement in cava vulva. The inguinofemoral group of lymph nodes, as we know, are the sentinel group of lymph nodes in cava vulva. So if the cava vulva is having involvement of the deep pelvic nodes, it's the worst case scenario. You know that cava vulva is a very grotesque surgery. It's a huge cancer removal and huge amount of skin pulling and undermining of the tissues to approximate them is required, and breakthrough of the wound and infection of the surgical wound is a major problem in cava vulva. A lot of us don't take much confidence in cava vulva surgery. It's nothing which a person with a slightly weak heart should be trying to do also, because it involves a lot of surgical skill, a lot of bleeding can happen, and in spite of best of your surgical skills and good apposition, wounds can break through because of the patient having a poor healing capacity. So yes, cava vulva, the major problem is the surgery, and the second major problem is the lymph node involvement. All right, please remember about cava vulva that it is one of the most morbid surgeries. The surgical morbidity of cava vulva is almost 40%. So 40% of mortality of cava vulva is because of the surgery itself. Large, grotesque, incisions and pulling up of tissues and releasing skin and pulling them in the midline and suturing them up. That causes a lot of breakdown of tissues. So that's why we say cava vulva, please try and limit the surgery. That's what we try to do, limit the surgery. So if a woman has cava vulva, then we know that if there's an ulcer here and this can be removed. We can do a simple vulvectomy in stage 1 and simple excision of this tumor, and do not have to take out the lymph nodes if they're not involved. But yes, in stage 2 onwards, what we do, we want to look if it is having lymph node involvement, because lymph node involvement makes it stage 3. So from stage 2 onward, we start thinking in terms of wide excision plus minus lymph node excision if there is involvement. So how do you look for the involvement in CA vulva? That we put a dye into this, and that dye, if suppose I put a technetium 99 dye here and it find its way into the inguinofemoral lymph node, and this is also having the same dye, then I know that this woman, suppose this is the thigh here, and this lymph node is positive. So yes, if this is positive, then the tumor is spreading to the lymph nodes. Then we have to do, along with a wide excision or a radical vulvectomy, if I do, along with that, I will have to take out the lymph nodes also. So along with the radical vulvectomy, I will also have to do the lymph node excision. So yes, what is the impetus? Stage 1 and stage 2, we just remove the tumor and the vulva and leave the lymph nodes. But if the lymph nodes are involved, then becomes stage 3, and those tumors we have to do a radical lymphadenectomy also. That lymphadenectomy is the reason for more grotesque and more morbid procedures, and subsequently the cause of death. That is one point about CA vulva. Please remember, the lymph node involvement of CA vulva starts in stage 3. We've discussed in the staging just before. And also important is that there is crossing over of the lymphatics from this right side. Suppose there is a tumor, it may involve the lymph nodes of the contralateral inguinal area. So there is crossover of the lymphatics, and the pelvic group of lymph nodes, the deep pelvic group of lymph nodes are not draining the vulva. So if they are involved, if the pelvic group of lymph nodes are involved, I've told you in the staging, then it becomes a stage 4 tumor. And we should also remember the basics of CA vulva, which we regularly asked in the exams, that yes, it is classically seen with women who are beyond 65 years of age, and it is older women, of course, and it is classically presenting with itching, the itch scratch cycle. If a patient has some irritation and she scratches, and the scratching releases some histamine, more itching, more scratching, and classical presentation of CA vulva is itching. And yes, it is not associated with HPV. The one which is associated with HPV is seen in the younger model, the younger women, and it is associated with HPV and smoking, and it is a multifocal lesion. And that's what is the basaloid variety. The basaloid variety of the vulval cancer, and the one which is seen in older women associated with itch scratch cycle and the lichen sclerosis. This is the keratinizing variety. So yes, the classical variety of CA vulva, the classical presentation is an older woman with itching, and it is not generally seen with the HPV. The HPV association is with the young woman and the basaloid variety. What is the HPV which is generally associated with CA vulva in the younger woman? What is the serotypes? Yes, it is the 6 and the 11.